Okay, so this is part of a series of advocacy town halls that NAMI-NYC has been doing to try to break down big policy solutions, big policy topics into solutions, and also bite-sized pieces for our audience and our membership. My name is Kimberly Blair. I'm the Director of Public Policy and Advocacy here at the National Alliance on Mental Illness of New York City. And I'm so thrilled and honored to be here discussing this topic today. We have here, now we're going to read the bios, the formal bios. We have New York State Senator Summer Brook, who represents the residents of New York's 55th District. That includes parts of Monroe County, including East and West, Irondequoit, Webster, Penfield, Parrington, Fairport, Pittsford, East Rochester, and the eastern portion of the city of Rochester. Senator Brook serves as chair on the Senate Mental Health Committee and is the leading sponsor of recent legislation pertaining to maternal mental health and doulas to improve pregnancy outcomes. We are also joined today by New York State Assembly member Phara Souffrant Forrest, who represents the 57th Assembly District in Brooklyn, which consists of neighborhoods of Fort Greene, Clinton Hill, as well as parts of Bedford-Stuyvesant and Crown Heights. She was first elected to the New York State Legislature in 2020. Before being elected to the Assembly, Phara worked as a maternal child field nurse, caring for new mothers and birthing people after they gave birth. Phara lives in Crown Heights with her husband and her son, who I've met myself, and is the cutest member of the legislature, might I add. Nadia Mbonde is a mad Black mother, scholar, mental health doula, and multimedia artist in Brooklyn, New York. She's a doctoral student in sociocultural anthropology at New York University. Nadia's research really addresses how perinatal mental health disparities contribute to the ongoing Black maternal mortality and morbidity crisis in the United States. As an artist, because she wears so many wonderful hats, Nadia also translates her own lived experience through dance, film, photography, and digital art. Nadia is also a NAMI-NYC Advocacy Ambassador, and we're so lucky to have her as part of our team. Tanya Niken is a clinical social worker who has worked in the public service to support women, children, and families in New York for over 20 years. Tanya is also a NAMI-NYC ambassador who will be sharing her lived experience with us today. And finally, last but not least, we have Alexandra Sachs. She is a doctor, specifically a psychiatrist affiliated with Columbia University Psychoanalytic Center for Training and Research. She's also affiliated with the Columbia Women's Mental Health Program. Her clinical practice focuses on psychotherapy and psychoanalysis, as well as women's mental health. She is board certified by the American Board of Psychiatry and Neurology, and is a graduate of the Adult Psychoanalysis at the Columbia University Psychoanalytic Center for Training and Research. She also has graduated from the Women's Mental Health Psychiatry Fellowship Program at Columbia University Medical Center, as well as the Weill Cornell Psychiatric Residency and Mount Sinai School of Medicine. She's an advocate and educator around issues of women's mental health via her TED Talks, and her New York Times articles. Her Motherhood Sessions podcast, which I encourage you all to check out, will be featuring that afterwards. And she's a co-author of the book, What No One Tells You, A Guide to Your Emotions from Pregnancy to Motherhood. Thank you all for joining us today. And we are now going to give the floor to our first speaker on this topic, who is Assemblymember Phara Souffrant Forrest, who will speak from her clinical, lived, and legislative insight at the intersection of perinatal health and mental health. Thank you, Phara.
Thank you so much, Kimberly. It's always a pleasure to join NAMI in important conversations such as maternal health tonight. And it's very important for us to keep in mind that, you know, mental health is part of maternal child health, right? And so this is why it's very important for me to be here in this conversation, both as a mom, as a nurse, and as a Black woman who has had her baby in the public health system in Brooklyn, okay? And so, as was said before, I'm Assemblymember for Forrest, and I'm really, you know, this issue is very dear to my heart. Some of you might know that I worked as a maternal health nurse before I was elected, and I saw firsthand both in the hospital setting, clinical setting, and in the home setting, just the disparities in care that Black and lower income mothers receive, and the mental health crisis. So when I talk about this from the experience. I worked at Kings County for a couple of years, and I followed women in the OBGYN clinic. And so I saw, you know, high risk births, low risk births. But one thing that was constant throughout is that on one hand, we're treating the women physiologically, but very rarely were we able to let me be fair. We did know that women were suffering with mental health issues, but in this, you know, world, in this society where, you know, capital is everything, and even the woman's womb is a capital, is part of capital, right? To insert the woman's mental health was really difficult. And so I remember one of the more touching, more cases where I knew I left a patient in a bad way. This woman just had her baby. It was a stillborn, and you know, she's also Haitian. Immigration status, not quite sure. She wouldn't disclose, but I knew that her immigration situation was insecure. And when I saw her, and I'm telling you, every time she comes to the clinic, you know, you follow these women for 20 weeks, some even 30 weeks, because sometimes they come in as soon as 6 weeks. So you're seeing her week by week go by, and she always had such a bright smile, such optimism. She was so happy to be here, safe, and be able to deliver her baby safely. When I saw her postpartum, it looked like literally a black cloud over this woman's face. Her speech was affected. Her manner of motion, the way she was walking, her gait was off. You could just see it in her eyes, like she was dead inside. And when I asked, it's because she literally had to give birth to a dead baby. And part of why her stillborn occurred, the stillborn happened, is because there was lack of education. And let me be real, as a nurse, I only have like 10 minutes, if that, to really impart onto this woman the importance of monitoring the movements of the baby, you know, being able to educate the family to, you know, support that education. And so she told me that the reason why she stayed so long at home, even though the baby wasn't moving, is because her mom told her, oh no, that's what babies do, they sleep. And so 24 hours, 36 hours passed, and she never sought treatment. So you can imagine this woman and where she is at postpartum. And, you know, these experiences only reinforced the needs for solutions when I gave to the birth to my son, David. Postpartum, I know, like, we talk about birth, we talk about prenatal health, but postpartum, that is the 4th trimester. That is in any other ways, BITCH. It is crazy because that's when you're kind of left alone. Your insurance cuts off at, you know, your insurance stopped covering inpatient after 3 days, and then they kick you out. And then you're at home 6 weeks. If you have C-section, they'll follow you up to 8 to 12 weeks. But after that, you're on your own. And we know that women are home alone. They're grappling with the realities of motherhood, baby blues, And then also the weight of having a baby in light of everything else that's going on in the home, joblessness, not having enough money in the savings bank, domestic issues. We don't talk about that, domestic issues, right? And then also the fact that she's going to have to go to work. And so that affects whether she breastfeeds or not. And so when we talk about baby friendly, we gotta talk about, is this economically friendly for this woman to actually breastfeed her child? And we know that breast is best. And so all of these experiences me convinced beyond a doubt that we must do more. And that's why I'm so proud to support NAMI and the work that they do around this issue. So again, I'm just here as a panelist. I'm here to, like, you know, if you have any questions, you can always drop in, but this is a very important, and can I also say this, and you could correct me because I forget the name of the screening all the time, but the Columbia scale, the PHQ-9 screening. But this is so crucial. And I'm very happy to see that King County and all the other health and hospitals corporation come together to really make sure that this is screened each and every visit, and that comes through legislation. So I'm very looking forward to not only making sure that health screenings, mental health screenings are part of the standard of care, but also screenings for like hepatitis C, and then also any other cytomegalovirus. Let's talk about that and how that affects children. So all of these screenings should be standard in part of our care when we're giving to mothers and babies. So, okay, let me not talk too much, but yes, thank you for having me. It's amazing.
No, I love that. I love that. Thank you so much for all that insight. We are just so lucky to have legislators at the forefront who also have that, you know, training in the field, who know the issues firsthand. And we're so grateful to have that critical piece of medical knowledge being incorporated into legislation. And for those who were curious, the questionnaire that Assemblymember Phara, Souffrant, Forrest was referring to was the PHQ-9. It's a depression screening that is supposed to be used with people who are experiencing part of the birthing experience and who are experiencing pregnancy. So we thank you for bringing that to our attention. And if anybody wants to know more about that, we could provide more information after this call. But I do know that you have to run, and thank you so much, Assemblymember, for joining us today. Thank you. And then so next up, we're going to have the experience of our state Senator Samra Brook, who's also, again, as I mentioned before in her bio, the Senate Chair on Mental Health, on the Committee on Mental Health. And so we're going to spotlight her now so that she can talk a little bit about all the wonderful, Senator, all the wonderful legislation that she has put forward in the intersections of reproductive health and mental health, and how we can address a lot of the postpartum phase, but also some of the mental health issues that we experience during the pregnancy process as well. Thank you, Senator.
Thank you. It's so wonderful to be here. And I probably could have listened to Assemblymember Forrest just keep talking all night. She's such a powerhouse in the Assembly, and I learned so much from her, and even from this panel have learned things from her. And really quickly, I do think, you know, the way she described individuals and legislators with other experience, both lived experience and professional experience, has really changed the way the legislature works, right? Because many of us had these careers, or we have these experiences that we bring with us. And I, for one, know for a fact that being chair of the Mental Health Committee, and because of the way that interacts with our physical health, I've actually literally learned from having someone with that type of medical experience, along with some others in our crew of moms in the legislature who come in with amazing experience. So It's so wonderful to be here with you all. Thank you for having me. I got to tell my little baby girl, I was like, Mom has to go do a panel. So, Dad's going to put you to bed tonight, but it's about babies and moms and birthing people. This is our stuff. This is what we love. And it's really been incredible to, start to work on some of these things before I knew I was going to have a child or planned on having a child, but then to go through it in real time while literally fighting to pass bills on maternal mental health while I'm dealing with identifying my own, maternal mental health status. And so it's really given me a different perspective. And so I want to talk a little bit about that work and the intersection, and also just always thinking about the fact that we have to talk about race and disparities when we're talking about these issues. And so that is a common theme when I'm talking about these things, because I'm sure you've already covered it at length, but we live in the most dangerous country in the developed world to give birth in. And unfortunately, even in a place like New York State that people believe to be progressive and to have these great outcomes, and we do well in many ways in other aspects, but we actually do not rank very well when it comes to maternal mortality and morbidity. And it is something that the state has been working on, but we are trending in the wrong direction. And then when you look at racial disparities within that, Black women are 5 times more likely to die in childbirth in New York State. And you may have covered this as well, but in New York City, where I know many of you are zooming in from, it's 9 times. So, this is not a good story. And one of the things that we've learned throughout our research is that maternal mental health conditions are not only one of the most common pregnancy complication affecting 1 in 5 birthing people, but here in New York State, our own maternal mortality board, our review board, has deemed it the 3rd leading, and you said this already, I'm sorry, I missed it, but yeah, the 3rd leading cause of maternal mortality. So let's just think about that. When we look at deaths in pregnancy or through the birthing process, to know that maternal mental health conditions are the 3rd highest leading cause of that, that's a major issue. And the fact that this state hasn't done more or hadn't done more before we jumped into this work last year is really, really appalling. And so as the mental health chair, and I'm very honored to serve as that in the Senate, as a Black woman and as a mother of a 1-year-old who just hit that, 1-year postpartum marker, which is such a major marker for people in New York and in the US, these things are very real to me. And so I've tried to use my own experience and try to kind of humanize this issue that shouldn't be hard to convince people to pay attention to. We're talking about people and their babies. So many times I tell folks, if we can't get it right to get a birthing person and their child through the birthing process and just start off life right, with the right nutrition, with the right mental health support, all of these things in place, what hope do we have for that child as an adult or a child going through the school system? There really is no hope if we can't get that right. And so I've really been trying to lean in any conversation we have around physical health, around birthing in general, we have to be talking about maternal health, maternal mental health as well. So I can share with you a few of the things that we have done in New York State. So one of those, and I'm not sure because I'm not a medical practitioner, if this is the same screening that Assemblymember Forrest was talking about, but one of the things that we've certainly seen, and I know many of you have seen, is that even when looking at the screenings that exist, and I think the one I took many times was the Edinburgh screening that I've gotten. I'm looking for the yes from the folks that know this. Thanks, Kim. So looking at some of these screenings, what often happens is that we're unable to identify when maybe there's a challenge with all birthing people, especially when you look at people with lower income, people where English is not the first language, looking at Black and Brown, BIPOC birthing people. Essentially what we've seen is that a lot of these screenings had a very specific woman in mind when they were created. And so one bill that I'm very excited was signed into law last year was really asking DOH and OMH to study these screenings and really identify, have there been disparate impacts in identifying potential maternal mental health conditions for Black and brown birthing people versus white versus cisgender versus trans, all of these identities, because what we believe is probably the case is that we aren't identifying social determinants and other things that really can help you identify where there's a challenge. So what was fascinating was, as we were passing this bill in the Senate, I was literally taking these screenings with my 1-month-old and 2-month-old at every single office visit with her, and with my own doctor as well, and could see in real time that sometimes, whether culturally or otherwise, if someone says, have you felt sad recently? That's not something that maybe you're going to answer, right? Maybe sad isn't the way you'd feel that. But if someone asks you, have you had a hard time? Have you been worried about paying rent? Have you been worried about feeding your child or yourself in the last week? Do you feel safe? All these different things that can be asked in these screenings could do a better job of identifying where people might have a challenge that needs to be addressed. Because that's the thing, overwhelmingly, any complication when it comes to maternal mental health are actually preventable. And that's our own New York State data that shows that. And so when you tell me as a legislator that over 70% of these either more maternal deaths or complications are preventable, that tells me you have to do a better job of identifying it to address it. So that's one bill that was signed into law. So we await the study on that, and then hopefully can actually enact some of the changes that come out of that. The other bill that has not been signed into law, but did pass one house, was expanded screenings. So this idea that we need to find more opportunities to do these screenings once we get them right. And even now, honestly, it can do more help than harm to at least have a screening. And so many doctors' offices, so in my experience, I got ad nauseum this screening. I happen to have a wonderful pediatrician we found for my daughter. Every single visit we went to, I was screened and given, in some cases, the privacy to be screened away from my husband as well, which is really important to be separate from the partner so you can get more honest answers. And so that's another bill that we have that would really expand the number of times these screenings are happening, to really make sure they're happening at all of these pediatric appointments, because anyone who knows, our appointments as the birthing people don't come for another month and a half. I didn't see my doctor for a month and a half. If you have a midwife, that might be different, but I know that 2 days after leaving the hospital, I had to take my baby into the pediatrician. So there are much more frequent visits. And so that's another bill. And then the last one on maternal mental health, which is very exciting, hot off the press. I don't know if you all know already, but in this year's budget, we were able to include our maternal mental health work group bill. And so that's very exciting, because if you were following this last year, I know we worked so hard to get it passed in both houses, and it was actually vetoed by the governor, which was, I don't think, the right choice. But she claimed that because it had a fiscal attached to it, AKA we had to spend money to do this work, that it needed to be done during the budget. So we pushed really hard to get this included in the budget. And I'm really excited to say that they've put $250,000 towards this work group alone. And one big bonus that maybe folks don't even realize, this is, we think, the only work group / task force that explicitly calls for reimbursing for childcare for any volunteer member of the work group. And that is to ensure that we have people most affected by maternal mental health conditions included in this work group. That's something I've been fighting for on work groups in general. These are all voluntary. You don't get paid to sit on any of these. And so the fact that people have to take time off work, come meet, they may have kids, especially if they're on a maternal mental health work group. So that's really, really an incredible leap forward that we were able to include with this work group. The last thing I'll say before handing it off, if you haven't talked about doulas yet, is doulas. I am a huge proponent of doulas, and I believe that they are a huge part of how we address maternal mental health. And I'll quickly just share my own personal story. I don't think I'd be here stable, both physically and mentally and emotionally, with an amazing relationship with my daughter, who is very healthy, 13 months now, if it weren't for my doula. And when it comes to maternal mental health, the most powerful thing she did was she came to my house when we had been home for about 3 days, after helping me figure out how to breastfeed and latch and all those other things that are important. But she asked me, how are you? And it was such a simple question, but no one had asked me that. When you give birth to objectively the cutest child that's ever existed, other than baby David, from Assemblymember Forrest, no one asks about you. Okay, for any mom or any person who's given birth here understands. No one asks about you. They're asking about the baby. They want to hold the baby. The baby's so cute. Is the baby doing this? The baby doing that? Is the baby gaining weight? And my doula just sat there and looked at me straight on and just asked how I was. And I remember feeling, wow, okay, let me think about that. And that was the first time someone had asked that. And it was the first time I was given the space to really reflect on, how am I doing? Do I feel anxious? Do I feel stressed? Do I feel depressed? Do I feel joy? And of course I felt all those things. But that was a huge part of making sure that I had the support I needed. And so I've been doing a big push right now to make sure we can get Medicaid reimbursement for doula care. I want to thank all of y'all's representatives in New York City, because New York City actually wrote a great letter in support of this to show the governor that we really do need to include this. And so we continue to work on that as well. I could keep talking about maternal mental health all day, but I'll leave it there and just want to say thank you to NAMI-NYC and really statewide, and to all of the advocates that work so hard on this and who use your lived experience to fuel the work that you do. Absolutely 100% sure I could never do some of the legislative things that we do without your help and your support, not just for maternal mental health, but everything that we've worked on, Daniel's Law, you name it. So I'm really, really glad to be here with you. So thank you.
Thank you so much, Senator, and thank you so much for sharing some of your lived experience. I know it's hard for some of us to be vulnerable, but when someone has such a big platform like you or the Assembly member, it's actually really important to see ourselves and see some of the same experiences that we might go through as birthing people on like a bigger platform. It just makes everything more tangible to us. And I feel like we really have made some great way with the maternal mental health packages that we've passed on before. And we are excited to keep supporting this new doula package. You know, I don't know, I have never really gone into this, but my background is actually in reproductive health and public health. And so I just remember through a lot of research how there's a lot of research that doulas are serving as protective factors when we talk about some of those maternal morbidity or mortality rates. So I'm really happy to hear this and to hear that we have some funding for some of the initiatives that we mentioned today. But before you go, I just want to bring something to everyone's attention, that we are using gender expansive language here. We acknowledge all birthing people or anyone who has the capacity to give birth as part of this town hall and part of our advocacy as well. So I just wanted to highlight for anybody who might be putting some questions in the Q&A, because that's where we're fielding them, that is why we are using some of this expansive terminology to make sure that everybody's seen on this panel. So thank you so much, Senator, for your time. And I'm going to now, before we engage with the next panel, the next panelist, we're actually going to spotlight as well the second interpreter. We have ASL interpretation today. So one moment while we get the second interpreter. Hi, Genevieve. Welcome. Nice to see you. All right, so now you just heard from your state Senate chair on the Committee on Mental Health. So let's bring it back a little locally. We, for the first time ever, are featuring two of our advocates from our ambassador program who are going to talk about a little bit from their lived experience, their research experience, their clinical practices, so that we can really bring this home and really talk about, you know, beyond postpartum depression, what really goes on when we talk about the intersections of reproductive and mental health. So I'm so happy to introduce to you Tanya Nyken, who I told you her bio before, but she speaks really truly from a clinical and lived experience. Again, 20 years in the field, and she's a NAMI-NYC ambassador. So welcome, Tanya.
Hi, everyone. Good evening. I'm sorry. I wanted to say good evening to the staff, NAMI staff, panelists, and our virtual audience. My name is Tanya, and I'm going to tell you a story this evening. I first encountered Tammy Grady at a local shelter. Tammy had fled family violence, had freed family relations with relatives, and was a new mother dealing with some difficult situations. Tammy had grappled with the choice of protecting her baby or discontinuing treatment for her serious mental illness during her perinatal period. With the recent birth of her baby girl, she was not attending to her mental health needs. My work was to help her adjust to the transition of being a new mother and to assess for postpartum depression. Tammy was diagnosed with bipolar disorder and schizoaffective disorder and had stopped receiving mental health treatment when she was pregnant with her baby girl. We know that she attended one session for medical management to address her symptoms of bipolar and schizoaffective disorder at a local community clinic, where she was prescribed Zoloft, which is a medication deemed effective in treating various mental health conditions to reduce symptoms associated with depression and anxiety disorders. It can also cause, withdrawal symptoms can occur if you stop abruptly. But Tammy did not begin taking this medication due to being pregnant. In addition, she was also missing appointments and had not been attending her therapy sessions and was not open to receiving or having any discussion regarding mental health due to stigma and fear. But she was feeling vulnerable, alone and afraid, and the situation of unstable housing as well. Her concerns were primarily based on the fact that she was breastfeeding her baby and was adamant about not taking any medication at the time. She was worried that antidepressants might be passed on to her baby through her breast milk. That was her primary concern. After assessments by our agency, I provided psychoeducation, informing her about baby blues and the time period, the postpartum depression feelings, etc., as well as getting a nurse to meet with her and her baby regularly. As a result, Tammy kept in touch with the local clinic that managed her mental health care needs. This helped her to get on board with exiting the shelter by connecting her with housing and towards enrolling herself into a vocational program, which helped Tammy to acquire skills to obtain her goal of being a hairstylist. So Tammy continued to receive treatment, eventually moving out of shelter to rebuild a more stable life. Tammy's case helps to demonstrate the importance of having a healthy, caring support system, but also how crucial it is to having local mental health programs and services in the community, where accessibility to life-saving care and treatment is so important, especially right now, in reaching our underserved families. Thank you. Time.
Thank you so much, Tanya, and thank you so much for sharing that experience. Just so that the folks know on the call, we are using pseudonyms to protect anonymity. So we want to make sure that everybody knows we're preserving that. And then also, Tanya, I'm really excited that you were able to bring this different angle, because oftentimes we don't even think of people who are experiencing housing instability as, you know, part of this whole birthing process. And so I really hope to be able to get in that into that with you in the chat in the discussion after we have Nadia, who is next, who is going to speak a little bit about her own lived experience. So Nadia, thank you so much for joining us today. Nadia, again, she's a busy student, a PhD candidate. I'm ready to start calling her Dr. Nadia, but she's also a big advocate and multimedia artist. So thank you so much for joining us today.
Hi, everyone. Thank you so much for being here. Thank you to the organizers, the interpreters, and everyone who made this happen. I am such a proud advocacy ambassador of NAMI-NYC, and I just want to say that I claim the collective political power in identifying as Black, queer, mad, and disabled. I unashamedly live with bipolar 1, and yet I know I'm so much more than my diagnosis. I'm the mother of a 3-year-old daughter. You may have seen her forehead here earlier. I'm also a medical anthropology PhD student at NYU studying Black maternal mental health. I am an artist and a mental health doula providing support to pregnant and postpartum people experiencing mental health challenges. So in 2019, I began my PhD program at NYU while pregnant. After 2 weeks of classes, I took leave for a year and almost didn't return. This is because I was experiencing severe symptoms of mania and psychosis, as well as depression and intrusive suicidal thoughts. It did not have to be this way. However, in my 6 years of living with a bipolar diagnosis at the time, not one psychiatrist, therapist, or OBGYN prepared me for what precautions I would need to take and what care I would need if I ever got pregnant. Due to the stigma of being a mother with a mental illness, I didn't trust the inconsistent information healthcare providers gave me. So I navigated one miscarriage and a subsequent rainbow pregnancy alone. I thought taking my meds would hurt my child, so I embarked on an unmedicated pregnancy. When the symptoms became too much to bear, I reached out to one maternal mental health center, but they did not take my insurance. Instead, they recommended I check myself into an ER. However, I was sent home several times without care because I refused to admit that I was experiencing suicidal thoughts. I did not want to be involuntarily committed and risk losing my bodily autonomy and potentially my parental rights. After experiencing mania-induced retinal detachment and emergency eye surgery, I was forced to rest. And sleep was actually the first step towards my recovery. Finally, out of the mania, I found a psychiatrist who took me in towards the end of my second trimester. She got me back on my lithium and introduced me to my first bipolar support group, which I attended for the remainder of my pregnancy and during my postpartum. These groups provide me with invaluable support to this day. I regained stability with no symptoms of mania or depression and gave birth to a healthy baby with the support of a birth doula, as well as postpartum doulas in the first 6 weeks after I gave birth. I was able to breastfeed while on my medication under my doctor's supervision, and now I have a chatty, witty, and healthy little toddler. Now, after studying Black maternal mental health for 5 years through my lived experience and work as a peer support specialist, mental health doula, and budding medical anthropologist, I know that my story does not have to repeat itself. I'm confident that if I have another child, I will not suffer needlessly. I will have the right supports in place, including a reproductive psychiatrist working with my OB, as well as invaluable mental health support groups and doulas, and last but not least, my medication. Maternal mental health is really my life's work. It is my calling, particularly to highlight the racial and socioeconomic disparities to accessing quality reproductive mental health care and to receiving education along the reproductive spectrum from mental health diagnoses that are pre-pregnancy to several years postpartum. This spectrum also includes reproductive experiences such as IVF, adoption, abortion, and pregnancy loss. I'm so grateful that the conversation on maternal mental health, particularly postpartum depression, is becoming more mainstream. However, I ask that our policy interventions include the full reproductive spectrum, as well as the entire range of maternal mental health conditions, or known as perinatal mood and anxiety disorders, which include bipolar, panic disorder, OCD, PTSD, and psychosis, as well as depression and anxiety. Thank you.
Thank you, Nadia. Thank you so much for opening up about your experience. I really thought your experience was really important, especially when we're talking about some of the legislation that State Senator Summer Brook is introducing to introduce doulas as part of kind of more mainstream as a protective factor for mental health outcomes, not just positive pregnancy outcomes. And it's good to know that through the work of peer support and a mixture of that with doulas, that you were able to really have the most, okay, I think everybody's the cutest baby. I need to stop calling everybody the cutest baby because I feel like now I'm being recorded. But yes, I really am so inspired by your story. So thank you so much for opening up today. And so now we're going to transition from talking about that lived experience to really what is the medical perspective, right? So we wanted to make sure that we had a medical perspective here on the call, which is Dr. Alexandra Sachs. Thank you for joining us today. But also we wanted to make sure that instead of leading the conversation with medical terminology and all the things that seem to boggle us up, that we kind of just rounded out the conversation that way. Because sometimes our lived experiences are not put at the forefront, and we are always focusing on just certain diagnoses, right? But here now, we're going to round off and really transition from that lived experience now to what are we seeing in general and what are you seeing in your practice? So thank you, Dr. Sachs, for joining us today.
Absolutely. And I just want to thank each and every one of you. I think, every time I sit down with a woman and a birthing person and parents, I learned so much. I learned so much from advocates. I really am just so inspired and touched and educated by each of the stories I've heard today. I'm not on the legislative side, and I'm so excited and so inspired and so grateful for those of you on this group who are working towards the legislation, because that is really what's so important, to empower clinicians and other people who are working to support birthing people to really try to help prevent and treat these conditions, especially that have such racial and socioeconomic disparities, worse in our country. What a shame, right? And so to be able to think about doing better, I think I really wanted to follow up on so many of the things that people said today, and mostly just add and reinforce that so many of these conditions are preventable and treatable. And what I heard in many of the stories we told today were really something I want to highlight, which is fears around medication, psychiatric medication use during pregnancy and postpartum. We have so much safety data at this point that is really reassuring. I think we heard before from one of the assembly people about how it's so rare that we ask people who are after birth, during birth, how are you? How are you? Not just the baby, right? And the history of that, the history of prioritizing the baby, is really reflected in how our medical system has educated both doctors and people like doulas, as well as birthing people, about this issue of medications during pregnancy and postpartum. The history was really, because the FDA doesn't include pregnant and birthing people in clinical trials, we don't have data. So it's just safest to take people off their medications. But actually, that's not true. And that's why, as we heard, that mental health consequences, which really can often mean suicide, are of the top 3 killers of pregnant and postpartum women and birthing people. So we know that it's not safe to put people's lives at risk, okay? And we have so much safety data that we've pulled now over the decades of more commonly using medications like Zoloft and using medications like lithium during pregnancy and breastfeeding. We see that the health of the birthing person and the baby are connected. Okay, we see that conditions like premature delivery are actually worsened by untreated mental health issues. Okay, so many of the conditions that people worry about in terms of exposure to medications during pregnancy and postpartum can actually be prevented by treating the conditions that flare up when we take people off the medications that keep them well. So that is so important. Now, access to care is really the issue. And I thank those of you who spoke up about, I went to the reproductive psychiatry center, but was turned away because they didn't take my insurance. That is the issue. So we talked about screeners, we talked about sociocultural and racial barriers to access to effective care and effective diagnosis, but we really also need to talk about expanding in-network care for reproductive mental health. And as you guys know, as the leaders of the National Association of Mental Illness, we really need to work on expanding in-network care for all mental health treatment in this country. So there's so much to do, but there's so much hope. These are preventable, treatable conditions. I think the main thing that I would like to reinforce is for people to read, to learn, to empower yourselves. Go to Postpartum Support International, go to the educational materials sponsored by the National Association of Mental Illness. You can learn about the risk-benefit association between treating mental illness, treating mental health during pregnancy and postpartum, and how that is not only one of the most important things you can do to keep yourself well, but actually one of the most important things you can do to keep your baby well, because the health of the birthing person and the baby are always connected. So I'm happy to answer questions about that, but I really just want to applaud everyone who spoke today and the work you're doing. And I have so much to learn from you. And I'm here to really just try to echo and support. So thank you.
Thank you so much, Dr. Sachs. Thank you so much for that perspective. And yeah, actually, you'd actually be surprised how many people are given misinformation almost that come to us or come to different places, such as the Center on Motherhood. Or I used to work with this group, the Black Mamas Matter Alliance. I encourage anyone to check it out. They're the first ones to really launch that campaign around the racial disparities in outcomes, in outcomes on Black maternal mortality and morbidity rates here in this country when compared to other groups. So without further ado, I think this is a good opportunity to transition into some questions. So I'm gonna bring back Tanya, and I'm gonna bring back Nadia, so that we can really get into the weeds of this. What is it that we're seeing? So the first question that we really have that we want to dispel or debunk or demystify for our audience members is, what do the reproductive options look like for folks with pre-existing mental health conditions? Like Dr. Sachs alluded to it, Nadia alluded to it some, but what is really out there for those of us who are contemplating, pregnancy, or whether or not to pursue that as an option, because we want to prioritize our mental health outcomes, either remaining in recovery or just making sure that we don't regress in certain ways in our recovery. So anyone would like to take that?
I'm happy to kick it off. I think the first thing that I would recommend, first of all, it's a privilege to have access to care before pregnancy, right? And so the first thing I would encourage is just for everyone, for all of us, all of us, is to talk next time you're at any sort of medical or mental health or any sort of clinical interface, to just say, hey, I wanted to just have a minute to talk and get any mental health screening. So, outside of pregnancy and pre-pregnancy, talk to your clinicians, use any healthcare interaction to sort of share any issues you're having with your mental health, which of course overlap with socio-demographics. So things like fears about your rent, fears about your safety with domestic violence and things like that. Talk to anyone who you think may be in a position to support and treat and diagnose. And then if you are in the position of planning a pregnancy, continue to talk, ask for more time, ask to speak up. If you have an unplanned pregnancy or a planned pregnancy, say, I need to plan and talk about how I'm going to be treating my mental health. What are my options? Can I have a risk benefit discussion? There are so many medications that you can stay on during pregnancy and breastfeeding. And then for those where there are complicated risk benefit decisions, there are alternatives. And for those people who want to go off their medications, there are non-medication based interventions that can be supportive and with close monitoring. So there's just so much you can do, but you need to ask for help. And in our medical system, where people get really pushed through, rushed through, put months on waiting lists, you need to demand care. And I would really then, switch this to anyone else in the group who wants to share more about their expertise and experience.
I want to second that, Dr. Sachs. I really wish when I was diagnosed at age 18, there was some kind of conversation, or at some point someone brought up the conversation. But what I'm realizing with my own mental health journey is that the onus is on me, unfortunately, to seek these answers and get this education. So yeah, start asking these questions, especially because oftentimes this is not planned. So to have a safety plan, like we do crisis planning for episodes and things like that, safety planning for pregnancy is also important. I would just like to also add, I am such a huge fan of support groups. Support groups are actually where I got the most education about my own diagnosis and my experience, and found people with brains like mine, and we could really trade notes, and I could really hone in on, taking care of myself. So I want to also second the resource you provided, Postpartum Support International. They have, perinatal psychosis groups. I helped found the first bipolar perinatal group there. They have general groups for, perinatal mood and anxiety disorders. They have groups for Black moms, all kinds of different demographics. Is a place to go to, but any support groups in general, I just have found to be a game changer for me.
Amazing. And then yes, peer-to-peer support is really unbelievably helpful and successful. And so support groups and really just talking to other people who've dealt with this. Yeah. Thank you for your work.
Thank you both for that answer. And then we have a question that I just want to address from the chat. So the town hall, we are going to be opening it up for questions. So please do submit with your Q&A, and we'll give folks the opportunity to be able to really share their own experiences as well. We just want to make sure that we cover some groundwork and really expose some topics first. So thank you so much for asking that question. And so, we mentioned a lot of things today, and both, actually everybody on this panel really talked about racial, socioeconomic disparities and other identities that might really receive some bias from the medical community or maybe the general population, which puts folks at disadvantages for receiving proper care or having long-term positive outcomes with their perinatal mental health. So I really want to talk about, what are some of those specific racial and socioeconomic disparities that we're seeing in terms of screening? Let's talk about the screening process for birthing people and mental health outcomes. Like Tanya, for example, in the story that you relayed to us earlier, was there ever a screening process in the shelters for the person you were talking about? Could you talk a little bit about how this plays out in shelters? Oh, you're on mute.
Okay, so yes, absolutely. First of all, most of the clients that will come into all of the New York City shelters, and each shelter has its own intake service and assessment. So mostly they'll conduct assessments and they'll refer out that client to acquire specialized needs for their behavioral health care needs. So definitely screening is done, the PHQ-9, the GET, other screenings for substance use. They don't use expert because sometimes they might, depending on what agency, but screening for alcohol and substance use. So they do screenings, but they will also then refer to psychiatrists, psychologists, obstetrician, other healthcare team that will take care of the mom, and also they may have their own preference. So they will, depending on their insurance, again, as we mentioned earlier, they will seek out the best care. Most have said they want the best care. And so they go on to hospitals after that. But again, everyone does have, from my knowledge, from what I've seen, they were taken care of. Of course, that's, now being that COVID exacerbated many things and, elevated many of the old issues, heightened them. So, and now we're seeing severe cuts to many fundings, but I think that with the awareness of mothers and maternal issue across the country, this is getting a lot of attention now. So thank you.
Thank you. Thank you for sharing that. And, we actually recently also, with the help of City Council member Eric Botcher and the City Council in New York, we passed some legislation to make sure some of the 30 largest families with children shelters also have mental health access to mental health care and mental health practitioners. So that is definitely something that I hope moving forward will change some outcomes as well, when we think of maybe birthing people in the family unit, right? So what about the rest of the folks on the panel? What are some of the racial and socioeconomic disparities? We discussed access to care, but what about the screening process or even outcomes?
I just want to quickly speak to, in my research now, my dissertation research, I'm realizing that there is a translation and linguistic disconnect because not everybody identifies with psychiatric language, for instance. And there's different frameworks that people use to identify the experience that they go through. Some people may not pathologize what they're going through, not call it a disorder. It may mean something else to them. It may be a gift to them. So really acknowledging the language people use. That's why I talk about being mad as well as having a mental illness, because madness is a whole other framework with which you can understand people's lived experiences that are wider than just, psychiatric language. And then also just looking particularly with Black people and how we may talk about our mental health issues, it may be, we may say that we have a headache or our stomach hurts. And that's actually an indication that there's some kind of stress or anxiety or other thing that's going on. So also, I would love to see us expanding the screening and the language that is used in the screening to meet people where they are if it's outside of the scope of medicine or psychiatry.
Thank you so much. And thank you for raising awareness around that. I feel like when we talk a lot about disparities, it's also because initially we don't meet people where they're at, right? We don't take a step back in the process to really learn the language that some folks use, and that might be why we do miss some of those screenings. So it's a really good thing to point out. Thank you so much, Nadia. Anything you'd like to add, Alexandra? If not, we can move on to the next question, because I see that we have some burning questions from the
Yeah,
audience.
let's keep going. I think you guys all covered it really well.
Awesome. So we got here, you know, some folks talked about, I think, so Nadia was talking about a broader range of mental health, like the mental health spectrum, or a broad range of mental health concerns that people might have, right, during pregnancy or even before pregnancy. So could we talk a little bit about beyond postpartum depression? Like, what does it really mean to have postpartum mania or psychosis, and what is that experience like for some of the folks maybe on the call who were missed during the screenings, right?
Yeah, would you like to start, or do you want me to start with kind of the clinical perspective, and then you'll kind of join in with your, does that work? What's best for you? That's good? Okay. So, you know, I think postpartum depression, it's great that concept has gotten so popular and that we have reduced so much stigma and increased language about it. However, I think a problem about it, that those words postpartum depression, is that it makes it sound like there's this only one version, which is like you're sad. And even for people who have postpartum depression, really the most common clinical symptom that I often see is anxiety, is really fear about the baby's safety. And this is like a classic example, which is I'm exhausted, but I can't sleep because I'm up with all these worries about the baby. So that's a classic symptom of postpartum depression, right? And so really we need to expand this. That's why we've expanded the language, and it's kind of clunky, to perinatal mood and anxiety disorders, PMADs, but it's good to have this umbrella to remind people. And then, you know, it really, that doesn't even include psychotic disorders. So what we see is that anxiety disorders, including OCD, mood disorders, especially very much bipolar disorder with symptoms of mania and psychosis, flare up commonly in the third trimester of pregnancy and in the postpartum. And, you know, you mentioned, Nadia, how the first step in your treatment was sleep. So sleep deprivation is one, of course, people going off their medicines, being taken off their mood stabilizers like lithium, is a common precipitating factor of why we see so much flare up of bipolar 1 and mania. However, sleep deprivation is one of the other things that really is, anyone who has experienced themselves symptoms of mania or psychosis or in a loved one knows that sleep deprivation, like if you're working night shifts or if you're up taking care of a loved one, sleep deprivation is one of the most common triggers of a manic episode. So the sleep deprivation when you're taking care of a baby is real. Babies need to be fed every 2 hours. And so for so many people, it's a sleep deprivation, both from the symptoms of the third trimester of pregnancy, where you're up every couple hours needing to urinate, and then the sleep deprivation that comes from feeding the baby, that really, in addition to going off of your mood stabilizers, sets off brain chemistry. That is one of the most common triggers into symptoms of mania. And, you know, postpartum psychosis is, again, and not to stigmatize, and I really appreciate you saying that, you know, it's important to not to pathologize every experience that people have. But I do want to say that medically, statistically, postpartum psychosis is one of the most dangerous things that can happen in the postpartum. It's what we call a medical emergency, because those are the moments where people, psychosis is to lose perspective on what's real. And so when people get really scared that they're in danger, that's really when we hear the stories of people who fear the safety of their babies, so much so that they may even experience feelings of violence towards their babies, which is incredibly disturbing even to them. But it's really due to auditory and hallucinations, delusions that you are under attack and that your baby's under attack. And that's what your brain chemistry is telling you. So if you're ever experiencing yourself or seeing in a loved one symptoms of someone not sleeping, someone speaking with pressured speech, someone saying that they think they're in danger, or saying that they are worried about their own safety, that is really when you need to call 911. Because these are treatable conditions and these are preventable conditions. But when people are scared, now, as we know, 911 can be a scary thing too for people. to call, right? And feeling safe in the hands of mental health workers and the police. So, and like you mentioned, Nadia, so bravely, I'm scared, scared about child protective services, right? I mean, the one thing I would say as being someone who has done child protective screening for women who have been hospitalized with postpartum psychosis and bipolar 1 is that really, in my experience, the system is highly motivated to return babies to their parents and to not separate families, really. That mental health conditions are treatable. And of course, there are exceptions to every rule, but I would just really say, please do not avoid getting mental health care because you're afraid of your child being separated from you. Really, I think the system is highly motivated not to do that, and that treatable mental health conditions are not a criteria for child protective services and separating families. So, but yeah, that's just to talk about some of the many things, and I turn it over to Nadia, I think, and others who might want to.
Yeah, you covered a lot. So all I want to briefly talk about is the distinction between postpartum onset bipolar and psychosis, which is where, there's no pre-existing bipolar that the person knows of or psychotic episode, and it happens because, it's unknown, but some of the factors are the sleep deprivation and other stressors that can bring it on postpartum. That's not my experience. My experience is I got diagnosed with bipolar when I was 18 years old. And so what I experienced was like a stressor that brought on an episode because I already have this condition.
Yes.
So that is something I don't want people to feel scared that this is a common, it's actually not that common. Psychosis is not that common postpartum. It happens, the bipolar onset of, with psychosis and mania, and then a lifelong dealing with bipolar. It's not as common, but it happens. And then for some of us, we're just in this and we have to deal with it. And hopefully our mental health, providers and our OBs and all of those people are coordinating our care from the moment we receive diagnosis through our life course, so that we don't experience, going through it alone, which I shouldn't have had to do as well. And what I'd like to say too, in my mind, in my research, I think of maternal as like this long stretch of time from pre-diagnosis, because there's stressors, there's things that happen even in utero that, have effects on the unborn child later on in life. And that goes back to some of the racial and socioeconomic disparities that predispose us for certain experiences with our health. And then postpartum is forever. That's a slogan that we have in the doula community, that, once we cross that threshold of giving birth, whether it's a stillbirth, a live birth, abortion, whatever it is, we are postpartum, and postpartum is for life. So you may experience symptoms of depression 5 years from the actual birth, and that's actually normal. And it's something we also need to normalize, that there's a longer time frame besides pregnancy and postpartum, but you're not alone. There's a lot of us in this boat. So we're happy for you to join us, and we're gonna sail this together.
Such amazing points. And, you said before, that, I guess I learned that the onus is on me to ask for help. I really think that the system needs to change. And one of the things we're trying to do for people who are diagnosed with bipolar 1 before pregnancy, and thank you so much for calling attention to, the statistical very low rates of people who are, postpartum, everybody's sleep deprived postpartum, but very, very few percentage of that will experience postpartum psychosis. So thank you for adding on to that. But really, we're trying to, in the medical community, encourage things like the use of treating bipolar 1 with lithium and not Depakote, because lithium is a mood stabilizer that you can keep people on during pregnancy, whereas Depakote is associated with more birth defects. So we're really trying to help people in their lifelong experience of treating their mental health to be on pregnancy safe medications. And that's so important for prevention too. So thank you for all of the amazing points that you added there.
Thank you both. And so I just kind of want to talk about one last thing before we talk about resources and close out. I kind of wanted to open up the discussion about privilege, right? So I feel like a lot of the things that we talked about today, like a protective factor almost seems like privilege, right? And when we're thinking of like Tanya's story of the person that was going through all that, you know, what role, I guess, what role does privilege really play to either our detriment or to help us, right? I feel like some of us even are privileged to be in this room, this virtual room, to discuss these topics. But you know, how do we address privilege and then use that to like really do some outreach around this topic?
I'll defer to you guys to start.
So I would say, you know, since COVID, you know, is starting to, you know, ease off, and we're all coming together, a lot of things changed. And I mean, I speak only for our city. I think, you know, it had created a lot of awareness of what's happening within our society at all levels, and everyone seemed to want to be involved. I mean, from my perspective, I think everyone wants to help each other. And that's why we're seeing a burgeoning of support groups. They're creating a lot of local level grassroots programs on the streets. I mean, to try to connect one another with services. We don't want to see anyone suffering alone in this. And I see that people are out marching, trying to get awareness and trying to give that attention, as you say, to the privileges in our society and who benefits and who's lacking all of the services, and trying to abate the hindrances within our society so that collectively we can all promote health and well-being for one another. At least that's how I look at it. And now there are a lot of programs to get everyone, especially underserved population within our societies, from California to New York. People are trying to come together to bring everyone, you know, care and treatment, you know, or at least, you know, point them to resources so that they're not left out, you know. And I think that's right. Also, NAMI is so important because it has a national programs. And so people are becoming more aware of these issues that we're speaking of. So I think that's positive, that we're trying to break down barriers and address the needs in society.
Well, I appreciate you, Tanya, for closing us out with that perspective. We will be following up to the members on online. We will be following up with resources on how to really engage with these topics for yourselves or your loved ones. But I do want to always remind everybody on this call about the NAMI-NYC helpline. It is 212-684-3264. Again, that's 212-684-3264. Or if you or a loved one are experiencing a crisis, it is okay to dial 988, which is our national crisis hotline run by the National Suicide Crisis Hotline. And we specifically are very privileged in the city to have NYC Well be our call center to answer those calls. So I want to thank everybody who opened up and shared and engaged with these topics with us. Thank you always to our wonderful interpreters. We couldn't do these events without you. And thank you, Pamela. And thank you, Andy and Giselle on the Spanish channel. This now concludes the end of our program. And please do hit us up at advocacy@NAMI-NYC.org if you would like to talk more about this or join our Advocacy Ambassador program that Nadia and Tanya are a part of. Thank you so much.
Thank you.
Thank you. Bye. Have a good evening.